Welcome back to the second half of our presentation and discussion regarding thoracic anatomy. Hope you had a restful break. We'll now be doing some practice questions. The way I suggest we do this is, as you go through, take a piece of paper and a pen, write down your answer, and then we'll discuss them. So we'll have a look at each question. I'll give you some time to come up with your answer, and then we'll discuss the reason behind them. So the first question relates to intercostal spaces. I'll let you have a read through of those and then put down your opinion. So this is a straight multi-choice question. It's not a type X. The answer to this one, of course, is E. So going through them, A, collateral branches located superior to the main nerve in the neurovascular plane. We know that's incorrect. The collateral branch is on the inferior aspect of the intercostal space. B, neurovascular bundles between the external and internal intercostal muscles. We also know that that's incorrect. They're between the innermost and the internal intercostals. C, internal intercostal muscle as the main muscle of respiration. Of course, that's the diaphragm. D, levator costae muscles innervated by the anterior primary rami of the spinal nerves. Yeah, look, I mean, that one isn't going to be correct. They're going to be from the intercostal nerves. And E, intercostal nerves related inferior to the vein and arteries. We didn't actually cover this, although the structure or the order of it is vein artery nerve, VAN. So the intercostal nerve is related inferior to the vein and arteries. There are 31 questions in total. This is question number 2. The right coronary artery arises from the right aortic sinus, usually supplies the sinoatrial node, gives off a posterior interventricular branch, and provides the main blood supply of the conus arteriosus, otherwise known as the infundibulum. So these are all true. We discussed that the aortic sinuses are named after the arteries from which originate. It does usually supply the sinoatrial node in 60% of cases. It does give off a posterior interventricular branch, otherwise called a PDA, and it is the main blood supply of the conus arteriosus. There's an interesting relationship actually. You often do get an anastomotic branch from the left anterior descending, and they anastomose to form what is called the arterial ring of Vieussens, Vieussens. That won't be in your GSSE, but it's an interesting piece of anatomy. Okay, next question. The serous pericardium has the phrenic nerve supplying sensation to its parietal layer, encloses the aorta and pulmonary trunk in separate sheaths of its visceral layer, has an oblique sinus behind the left atrium, and has a transverse sinus directly behind both atria. I'll let you have an answer. So this type X question, 1 is true, the phrenic nerve does supply sensation to its parietal layer. 2 is false. So encloses the aorta and pulmonary trunk in separate sheaths of its visceral layer, so they are enclosed in one sheath, which is what forms the transverse sinus behind it. 3 is true, the oblique sinus is directly behind the left atria. And 4 has a transverse sinus directly behind both atria. Well, we've explained in 2 why that one is incorrect. The transverse sinus is surrounding the aorta, well, it's behind the aorta and the pulmonary artery, and those will occur above the roof of the left atrium. Okay, so this is a type A question, a straight multi-choice. The right atrium lies anterior to the left atrium, receives blood from all the venae cordis minimi, has its left wall formed by the interventricular septum, has the coronary sinus opening to the right of the fossa ovalis, and has a valve for the superior vena cava. And the answer to that one is A. So this again highlights what we were saying about the relation between the right and the left atrium. They are AP structures. And so it does lie anterior. So it receives blood from all the venae cordis minimi. Well, venae cordis minimi drain into every chamber of the heart, so that's not correct. C has its left wall formed by the interventricular septum. That is incorrect. It will be the majority of the posterior wall, apart from the sinus portion. D has the coronary sinus opening to the right of the fossa ovalis. That will be slightly inferior and to the left, and has a valve for the superior vena cava. The superior vena cava often doesn't have a valve. The inferior vena cava often does, and it's called a eustachian valve. Okay, another type A question. The superior mediastinum contains the left phrenic nerve passing medial to the left vagus nerve just above the arch of the aorta, left superior intercostal vein, whole of the superior vena cava, esophagus held to the left of the midline by the aorta, and the origin of the right recurrent laryngeal nerve. So this question, you need to think about that diagram I showed you with the relation of the superior intercostal vein and the phrenic and the vagus nerves, as well as to think back to our mnemonic of claptrap. So the superior mediastinum, it does not have the left phrenic nerve passing medial to the left vagus nerve just above the arch of the aorta. The phrenic will be passing lateral and anterior. It does, however, have a left superior intercostal vein which passes across the arch of the aorta. It does not have the whole of the superior vena cava because some of that will be in the middle mediastinum. The esophagus is not held to the left of the midline by the aorta. And the origin of the right recurrent laryngeal nerve will also be at the level of the subclavian artery, which is not in the superior mediastinum. Next one is another type X, true, false. Coronary venous blood returns directly to the right atrium via, this is one of my favourite questions, the coronary sinus is true, so the coronary sinus does return directly to the right atrium. The venae cordis minimi, the small heart veins in Latin, yes, they do in some cases open into the right atrium. Remember we mentioned before that they also do open into other chambers, but they do directly return to the right atrium. The anterior cardiac veins, remember we talked about those opening into the anterior aspect of the atrioventricular groove into the right atrium. So that is also true. Number 4, the oblique vein of Marshall. That is actually false. The reason being is because the oblique vein of Marshall opens into the coronary sinus. So the blood drains from the oblique vein of Marshall into the coronary sinus and then into the right atrium. So that one isn't direct. So the oblique vein of Marshall, remember, is the remnant of the left superior vena, the left superior vena cava, which is obliterated during embryology. Okay, we have another type X question. The atrioventricular node lies subendocardially within the interatrial septum, lies above the opening of the coronary sinus, is supplied with blood from the left coronary artery in 60% of individuals, and lies above the anterior cusp of the tricuspid valve. So we have number 1 lies subendocardially within the interatrial septum. That is true. Remember, it lies at the apex of the triangle of Koch, KOCH. 2 lies above the opening of the coronary sinus. Look, that's not the greatest wording. The coronary sinus forms the base of the triangle of Koch. So by definition, yes, it is above, remembering that the other two structures are the septal leaflet of the tricuspid valve and the tendon of Todaro. 3 is supplied with blood from the left coronary artery in 60% of individuals. That is false. It's only supplied with blood from the left coronary artery in 20%. Remember, 80% is from the right. And 4 lies above the anterior cusp of the tricuspid valve. That is false because it would be above the septal leaflet of the tricuspid valve. Okay, this is a type A question, straight multi-choice. In the valves of the heart, the mitral valve has 3 cusps. The aortic sound is best heard at the apex. The interatrial and interventricular septi lie at about 45 degrees to the sagittal plane. The tricuspid valve has 2 large papillary muscles, and the right coronary artery arises from the right posterior aortic sinus. The answer to this one is C, and we'll go through the other ones and say why they are false. So A, the mitral valve, as we know, has 2 cusps. Likewise, it is the mitral valve that is best heard at the apex. D, the tricuspid valve has 2 large papillary muscles. Well, we know that there are actually 3 large papillary muscles that subtend the chordae tendineae of the tricuspid valve. And E, the right coronary artery arises from the right posterior aortic sinus. If the word posterior wasn't included, that would be true. However, the right coronary sinus is actually very anterior. So that's incorrect as well, leaving C to be the correct answer. The interatrial interventricular septi lie at about 45 degrees to the sagittal plane. Look, that's probably not quite enough. It's probably a little bit more of that. They are actually fairly close to the coronal plane, but it's pretty close. So we'll go with that. Okay, next question. The diaphragmatic surface of the heart consists of parts of the right atrium, atrioventricular groove, right ventricle, and left ventricle. This is a type X true-false question. I'll give you a chance to write down your answer. These are all true. So remember we said that the diaphragmatic surface does consist of the right atrium, especially where the IVC joins. It certainly has atrioventricular groove there, and there is right ventricle and left ventricle. These make up the most of the diaphragmatic surface of the heart. The right ventricle about 1/3, the left ventricle about 2/3. Next question, another type X. The left atrioventricular valve, or mitral valve, 1 has an anterior septal cusp with a larger atrioventricular ring attachment than the posterior cusp. 2 can be a tricuspid valve. 3 has a small posterior cusp. 4 has thicker cusps than the right atrioventricular valve, also known as the tricuspid valve. I'll give you a chance to answer those. The first one is false. We didn't really talk too much about the finer points of the size of the cusps of the mitral valve, but the anterior mitral leaflet only occupies 1/3 of the annulus, and its anterior cusp is actually larger in area, or they're actually about the same, but it occupies about 2/3 of the valve area, but it only occupies 1/3 of the annulus, so that is incorrect. 2 can be a tricuspid valve. Well, that is true. You can have cleft leaflets, and you also can have variations in the number of cusps. Most of the time it is bicuspid, but it can be tricuspid as well. 3 has a small posterior cusp. Well, if you were talking about the tricuspid valve, that would be true. The posterior cusp of the tricuspid valve is smaller than the other two. However, in the mitral valve, the posterior cusp is 2/3 of the annulus, so that is incorrect. And then 4 is true, has thicker cusps than the right atrioventricular valve. The cusps of the mitral valve are much thicker than those of the tricuspid, so that is true. Another type X on the right coronary artery, and this one is identical to the one we've had before, so we'll quickly go through. So the right coronary artery does arise from the right aortic sinus, that is true. 2 usually supplies the sinoatrial node, yes it does in 60% of people. 3 gives off a posterior interventricular branch. In most people it does, in 85% of the population who are right dominant. The other 10% being left dominant, with a posterior interventricular either coming from a wraparound LAD or left anterior interventricular, or from a distal circumflex branch, and 4 providing the main blood supply of the conus arteriosus, which is true. We did mention the anastomotic ring of Vuissens for interest when we last tackled this question. Next question, another type X, the ascending aorta, gives origin to the right coronary artery from its anterior sinus. 2 is a posterior relation of the left auricle. 3 is encased in a common pericardial sheath with the pulmonary trunk. And 4 is an anterior relation of the right atrium. I'll give you a chance to go through and write your answers. Okay, so the first one is true. The ascending aorta does give origin to the right coronary artery from its anterior sinus. So remembering that anterior is one way of naming it, but we would normally call it the right coronary sinus, but that is actually anterior. And the left is very posterior. 2 is a posterior relation of the left auricle. Well, the left auricle, it's a posterior relation of the right auricle, so that one is false. 3 is encased in a common pericardial sheath with the pulmonary trunk, that is true. And 4 is an anterior relation of the right atrium. Well, we've mentioned before that it's a posterior relation of the left auricle, of the right auricle, so it is not an anterior relation of the right atrium, it is a posterior relation of the right atrium. Next question, another type X, the right pulmonary artery is shorter and smaller than the left pulmonary artery, is an anterior relation of the azygous vein, divides at the root of the right lung into 2 branches, and is a posterior relation of the thoracic duct. I'll give you a chance to write down your answers. All right, the right pulmonary artery is not shorter and smaller than the left pulmonary artery. That is false. The left pulmonary artery is much shorter and smaller. The right pulmonary artery, following the pulmonary trunk bifurcation, has to travel under the arch of the aorta as well as under the superior vena cava before it branches outside of the root of the lung. 2 is an anterior relation of the azygous vein. Well, look, that one's not a great question. The azygous vein loops up and over the hilum, so it is anterior to the azygous vein for a portion. However, when the azygous vein then comes over the hilum, it's an inferior relation. So that one is false. 3 divides at the root of the right lung into 2 branches. Yes, that's true. So at the root it does divide. So it's actually outside of the lung hilum that it's already given off its upper lobe branch. And 4 is false. It is a posterior relation of the thoracic duct. You remember where the thoracic duct lives? It's one of the 4 birds of the posterior mediastinum. So the thoracic duct is a posterior relation of the pulmonary artery in a sense. Okay, next another type X, the superior vena cava, fuses with the fibrous pericardium, is formed by the union of the brachiocephalic veins, receive the azygous vein opposite the second right costal cartilage, and represents the persistent of part of the right anterior cardinal vein. I'll give you a chance. Okay, all of those are true. So the superior vena cava does form with the fuse with the fibrous pericardium. Remember that the fibrous pericardium forms, will actually go off into the adventitia of all of those vessels. We did mention that there was an exception to that, and that was the IVC, as it's inseparably blended with the diaphragm. So number 2 is formed by the union of the brachiocephalic veins. If you recall back to the hand-drawn diagram, it was formed by the left and the right brachiocephalic veins, the right being very short, the left crossing from left to right and travelling down a space. 3 receives the azygous vein opposite the second right costal cartilage. That is also true. Now, there are two ways to know this. Number one is from that diagram I drew, which shows the azygous veins going from the first costal cartilage, or the first sternocostal joint, through to the second costal cartilage, and then at the third costal cartilage was when the superior vena cava entered into the atrium at the cavo-atrial junction. The other way is to remember claptrap, all of the things that occur at the transverse thoracic plane, and one of those is the azygous vein joining the SVC. And 4 is correct as well, because embryology. Okay, another type X on the same question, or on the same topic. The superior vena cava has the right phrenic nerve on its lateral side, receives the azygous vein, lies anterior to the right pulmonary artery, and lies to the left of the transverse sinus of the pericardium. I'll give you a chance to give some answers. Okay, has the right phrenic nerve on its lateral side? Well, yes it does, that is true. Remember that the right phrenic nerve will actually follow the SVC on its lateral side, and then it will pass anterior to the hilum. Receives the azygous vein, we discussed that in the previous question. Yes it does, at the transverse thoracic plane, so of T4 through to the manubriosternal joint, or the angle of Louis. 3 lies anterior to the right pulmonary artery. We mentioned that before in terms of the length of the right pulmonary artery. It does indeed. The right pulmonary artery is posterior to the SVC, so it does lie anterior. And 4 lies to the left of the transverse sinus of the pericardium. No, it lies to the right. So the SVC is on the right, as are most of the venous structures. They're either to the right or to the midline. So the SVC, the IVC, are all to the right, and the pulmonary veins are symmetrical and quite midline. Okay, another type X question. The left vagus in the thorax is held off the trachea by the great arteries, is crossed by the left phrenic nerve just above the arch of the aorta, is crossed by the left superior intercostal vein on the arch of the aorta, and runs posteriorly to the root of the left lung. Okay, now these are all true. Number one, it is held off the trachea by the great arteries. That is true, and again there was a difference on the right and the left. Remember that the trachea is exposed to the pleura on the right. On the left, the trachea does not come into contact with the pleura because of the great arteries being present. 2 is crossed by the left phrenic nerve just above the arch of the aorta. Yes, that is also true. Number 3 is crossed by the left superior intercostal vein on the arch of the aorta. Yes, that is true. Remember that it passes lateral to the left vagus, however it runs medial to the phrenic. And 4 runs posterior to the root of the left lung. That is also true. The vagus runs anterior to the hilum. The phrenic runs anterior to the hilum, the vagus runs to the left. Interestingly enough, I would say from a semantic point of view that is correct, because they have said the left vagus. If they had said the left vagus nerve, then number 4 would be incorrect, because by the time that the vagus is at the level of the hilum, it should already have formed the vagal trunks. Or should be forming the vagal plexuses and forming the vagal trunk, so it should no longer be the vagus nerve. And remember, the left becomes the anterior vagal trunk and the right becomes the posterior vagal trunk. So LARP, L-A-R-P, was the mnemonic that I mentioned in the main talk for that. Another type X, the right phrenic nerve, runs subpleurally lateral to the right brachiocephalic vein, runs anterior to the root of the right lung, runs over the fibrous pericardium covering the right atrium, and penetrates the diaphragm through or just lateral to the opening for the inferior vena cava. I'll give you a chance to have a go. Okay, these are all true. Number 1 runs subpleurally lateral to the right brachiocephalic vein. We didn't cover that specifically. Remember, we can't be entirely prescriptive in a 1-hour lecture. However, that is true. 2 runs anterior to the root of the right lung. Yes, that is true. The phrenic does run anterior. The vagus runs posterior. 3 runs over the fibrous pericardium covering the right atrium. That is also true. And 4 penetrates the diaphragm through or just lateral to the opening for the inferior vena cava. Going back to our discussion on the foramen of the diaphragm and what goes through what, yes it does, and that occurs at the level of T8. Just a note that the phrenic nerves do run over the fibrous pericardium on both sides anterior to the hilum, and the vagus accompanies the esophagus. Another type X, the thoracic trachea, is directly related to the right lung and pleura, lies immediately posterior to the brachiocephalic artery, does not contact the left lung and pleura directly, and has the bifurcation of the pulmonary trunk directly anterior. Okay, going through these. The first one is true. It is directly related to the right lung and pleura. Remember, we talked about this as an exception, or where things are different on sides. Lies immediately posterior to the brachiocephalic artery. That is also true. Number 3, does not contact the left lung and pleura directly. Again, this goes back to our comments surrounding 1. So that is also true because the great vessels hold it off. And 4 has the bifurcation of the pulmonary trunk directly anterior. This is a tricky one. So if we go back to claptrap, so we know that you actually get the tracheal bifurcation as well as the bifurcation of the pulmonary trunk happening at the level of the transverse thoracic plane of Ludwig. Look, I would have said that the pulmonary trunk is a little bit inferior and anterior to the trachea. I think if they said that the bifurcation of the pulmonary trunk occurs anterior to the tracheal bifurcation, that would be true. However, because they have said the bifurcation of the pulmonary trunk directly anterior to the thoracic trachea, that is not true. So the number 4 is false. Another type X on the diaphragm, the sympathetic trunk passes behind the medial arcuate ligament. The subcostal nerve and vessels pass behind the lateral arcuate ligament. The greater and lesser splanchnic nerves pierce each crew, and the neurovascular bundles of the 7th to 11th intercostal spaces pass between the digitations of the diaphragm and transversus abdominis into the neurovascular plane of the abdominal wall. Okay, again, these are all true. So the sympathetic trunk does pass behind the medial arcuate ligament, and the subcostal nerve and vessels do pass behind the lateral arcuate ligament, as well as the greater and lesser splanchnic nerves piercing each crew. Those just, you have to refer back to our discussion regarding the foramina of the diaphragm and what goes through what and at what level. So those are very common questions in the GSSE. you're likely to get asked about it. Number 4 is really one to use as a discriminator. It is true. So the neurovascular bundles of the 7th to 11th intercostal spaces do pass between the digitations of the diaphragm and transversus abdominis into the neurovascular plane of the abdominal wall. So that neurovascular plane between the innermost and the internal intercostals is the same as the neurovascular plane in the abdominal wall. Next one. The arterial supply of the posterior part of the first intercostal space arises from A, the arch of the aorta, B, the descending aorta, C, the suprascapular artery, D, the costocervical trunk, and E, the transverse cervical artery. So this is a type A question. It's a straight multi-choice, and I will let you have a go, and we'll come back with the answer soon. The answer to this question is D. It is the costocervical trunk. Remember that the first 2 ribs are the exception to the rule. The rest of the intercostal spaces derive their blood supply from their segmental levels, and so they would be coming from the descending thoracic aorta. And then, of course, anteriorly they come from the intercostal branches of the left internal thoracic artery, also known as the left internal mammary artery, and a very important structure for cardiothoracic surgery. So going back to this question, the posterior part of the first 2 intercostal spaces comes from D, the costocervical trunk. They've mentioned the first, so we'll go with that. Okay, another type X, true false, at the level of the second costal cartilage, which is another way of saying the transthoracic plane. The superior vena cava receives the azygos vein. The esophagus is a midline structure. The left main bronchus arises, and the right recurrent laryngeal nerve hooks around the arch of the aorta. I'll give you a chance to write down your answers. So this question is really testing whether you know what structures occur at the transthoracic plane, or the transverse thoracic plane, I should say. And so it's actually quite easy. So number 1 is true. The superior vena cava does receive the azygos vein. 2, the esophagus is a midline structure. Well, yes, we do know that. It becomes slightly to the left as it passes through the diaphragm. 3, the left main bronchus arises. Well, the trachea bifurcates at the transverse thoracic plane, so yes, the left main bronchus does arise. And 4, this is a trick question, so this one's actually false. So it's designed to make you think, well, the right recurrent laryngeal nerve hooks around the arch of the aorta, because remember that the arch of the aorta does go it does form the lesser surface of it anyway at the transverse thoracic plane, and also you do have the ligamentum arteriosum, which is what the left recurrent laryngeal nerve hooks around. So if that said the left recurrent laryngeal nerve, that would be true. However, because it says the right, it is false. Very similar question here. This is a type A question, and again, it is related to the transverse thoracic plane. At the level of the manubriosternal angle, the angle of Louis, the left common carotid artery commences, the second costal cartilage articulates, the brachiocephalic vein join, the right recurrent laryngeal nerve recurves, and the phrenic nerve has the vagus nerve related anteriorly. I'll give you a chance to pop down your answer. Okay, so the answer is B. The second costal cartilage articulates, and we'll go through and say why they are. So the left common carotid artery commences. Well, at the transverse thoracic plane, you have the lesser curvature of the aorta, so the left common carotid artery is above this. B, the second costal cartilage articulates. We do know that. C, the brachiocephalic veins join. That one happens one space above. So the azygous vein joins in that space rather than the brachiocephalic veins joining. D, the right recurrent laryngeal nerve recurves. If it said left, it would be correct because that would be happening at the same level as the ductus, but the right hooks around the subclavian to then run in the tracheoesophageal groove. And then E, the phrenic nerve has the vagus nerve related anteriorly. We know that the phrenic's anterior to the vagus. Okay. The classical posterolateral thoracotomy incision in the fifth interspace, individual muscles divided include 1. Transversus thoracus, 2. Latissimus dorsi, 3. External intercostal, and 4. serratus anterior. Quickly let you go through those. So in a classical posterolateral thoracotomy, you divide latissimus dorsi followed by serratus anterior, and then you divide the muscles of the intercostal space in all of the layers, which would include the external intercostal. However, you do not, in a standard posterolateral thoracotomy, divide transversus thoracus. So hence it is false, true, true, true. Another type X question, this time about the esophagus. So the esophagus is encircled by fibres of the left crew as it passes through the diaphragm, has a coat containing non-striated muscle fibres in its lower 2/3, is in contact with the right mediastinal pleura in the posterior mediastinum, and pierces the diaphragm at the level of the 10th thoracic vertebra. I'll give you a chance to write your answers. Okay, number 1 is false. It's actually encircled by fibres of the right crew. Number 2 has a coat containing non-striated muscle fibres in its lower 2/3. Yes, that is correct. Remember that it starts off as striated and then becomes non-striated with a transition somewhere in the middle third. 3 is in contact with the right mediastinal pleura in the posterior mediastinum. Yes, it is. You can see the esophagus from the right. 4 pierces the diaphragm at the level of the 10th thoracic vertebra. Yes, it does, through the left and right crew as we discussed before. So I'm going to very quickly talk to you about how you approach the GSSE. My biggest tip would be to have a plan. So write down how you're going to approach it, how much time you're going to spend on each individual section, and that's what you should do. The college publishes on their website a list of how many questions get asked about each region, and that's how I divided my time. So for instance, there's usually around about 11 questions on the thorax, about 13 on the abdomen, and 11 on the pelvis, and only 3 on neurosurgery. I'm going off the top of my head here, you'll have to confirm that. But it's around those numbers. So essentially the time on each of those sections should be 3 to 4 times as long as your time spent on neurosurgery. And use the bank. That's my biggest tip for neurosurgery. Study the differences and the exceptions. We've seen many examples of that. The bank is your friend. If you know the bank well, then you will know the style of questions. And there's actually a lot of questions there with a lot of variations. So I would encourage you to do the reading and to do the study, but know the bank extremely well. As you plan to go through, as I say, get the college list, and there it is. Abdomen was 9. And Thorax is also 9, but CNS is 3, so it is 3 times as many questions on the abdomen as there is on the central nervous system. So know what they are, know what the question breakdown is, and allocate your time on the basis of this, and give yourself some time at the end to come back over what you've already covered and look at things again. Okay, so this is how I did it. I had a 12-week study plan, 4 weeks anatomy, 2 weeks pathology, 2 weeks physiology, and then 4 weeks at the end going over everything, and I did take a couple of weeks off work. When you get there, in any exam, I like to go for the easy questions first. I just find that it improves my confidence, it gets me ahead of time, and it means that, you know, if I need to come back to something I need to give a bit more thought to because I think the wording's a bit off, then I've got the time later on. So go through, know the bank, practice the style of questions, but always read the questions carefully, because sometimes what they do is they take questions from the bank and they just change a left to right, as you saw they can do with the SVC, they can do it with the recurrent laryngeal nerves, and they can change the entire meaning of the question. There's a flag function in the software, so make sure you use it. And if in doubt, guess. On Type X questions, there's a 50-50 chance. It's probably true. So I always guess true. It served me well. Your mileage may vary, but that's what I'd suggest. And just manage your time. That's why I answer easy questions first. Well, here's a couple more questions. We'll quickly go through them, but I'll just tell you what the answers are. You can pause it when you come to reviewing it if you like. The lower part of the body of the sternum, A1, forms a secondary cartilaginous joint with a xiphoid process. That is true. Remember we said it was secondary cartilaginous. 2, articulates via synovial joints with the 5th, 6th and 7th. Yes, it does. Above them they are primary cartilaginous, and they're secondary cartilaginous above, but the synovial joints, which are forming the costal margin, are synovial. Is attached to the xiphoid process at the level of the 8th thoracic vertebra. That is also true, and then has the superior epigastric vessels related posteromedially. They are posterolateral. Another one, the anterior supply to the intercostal spaces are, this is a type A, so it's a multi-choice, and this is the same thing that we spoke about before. So posteriorly from the superior intercostal branch of the costocervical trunk to the first 2 spaces, which is D, and so we'll go through the other ones. A is incorrect. Anteriorly directly from the subclavian artery, no, it's from the internal thoracic artery, which is a branch of the subclavian. B, anteriorly from the superior epigastric, is also incorrect. The superior epigastric is a terminal branch of the internal thoracic artery. C, posteriorly from the vertebral artery. Well, the vertebral artery is another branch of the subclavian, but not this time. And then the costocervical trunk. So those are the 3 branches of the first part of the subclavian. And then E, posteriorly from the inferior phrenic arteries. No, certainly is not. Okay, the diaphragm develops in part from the septum transversum. We said that that was the case when we went through. Has part of the right crew that lies to the left of the esophagus, supplied by the right phrenic nerve. That is incorrect. 3, has a caval opening lying behind the right 8th costal cartilage. Incorrect, because remember we said that that was the esophageal opening. The caval opening is in the 10th. And then 4, has the right phrenic nerve supplying the muscle from its superior surface. No, they come from underneath. The coronary sinus, 1, receives almost myocardial blood flow. That is true. Lies below the opening of the inferior pulmonary veins. That is also true. 3, receives the anterior cardiac veins. No, it doesn't. They drain directly into the right atrium through the anterior portion of the atrioventricular groove. And 4, opens into the posterior wall of the right atrium. That is also true. So just as I leave you, here's a picture of when I was studying. So that's my daughter Cora, as I have the Fick equation written on her whiteboard. She wasn't walking and she wasn't talking when I started studying. She certainly was by the end of it. And, it is hard. You will have a table that looks like that. Sometimes a lot messier. You can see I have a lower limb, including a femur, a tibia, and a fibula, and a patella. But it will be over before you know it. So look, I'd like to thank you for coming along today and for listening in and for your attention. I do hope that you gained something from our discussion of thoracic anatomy. I based this talk largely around lasts, however I did use some other resources, and especially the thoracic surgery clinics of North America are very good resources. They're available through most hospital libraries, but I have based this largely off lasts because that's what will appear in the exam. But again, I'd like to thank you, wish you the best of luck. If you do have any questions, that's how to get hold of me. All the best.